Good evening, everyone. Good evening. Great. So it's lovely to meet on this targeted Tuesday from medicine. I'm Dr. Srinath. So today's choice of MCQ and a approach table to this MCQ we are going to discuss today. In this sure shot MCQ, we want to learn how to identify. So good evening. How to identify the feature which differentiates the Bartter syndrome from the Gitelman syndrome. The feature which differentiates the Bartter syndrome from Gitelman's syndrome we want to learn today. So in INI-CET this question had come, and 2 years back also we are having questions related to channelopathies. So these are two rare topics in nephrology but common topics in the exam. So today we are going to discuss these two topics here, the approach to this question, right? So as Sagar Khane has already said that the diagnosis or the answer we know, but as I always say, knowing the answer alone does not mean necessarily that we know the concept also. So we want to learn the concept along with the answer also. Both we want to learn in this session. So what are the points? So to understand, we will go back to a little approach table of the metabolic alkalosis. Let us start at the top. Approach table to a metabolic alkalosis. Let us learn today. So this is the targeted flowcharts we want to learn for approach to patient with metabolic alkalosis. Approach to patient with metabolic alkalosis we want to learn. In patient with metabolic alkalosis, the causes of metabolic acidosis, the causes and the mechanisms. The causes and the mechanisms are going to be based on the urinary chloride levels. Can be classified based on the urinary chloride levels. We want to classify based on the urine chloride level. We want to see both the causes also, and we want to see our mechanisms of the disease. So is the video audible to all of you? Yes. So based on the urine chloride level, we want to classify the causes of metabolic alkalosis into the two. Yes. So based on, if urine chloride level is low, we say it is the GI cause. So we want to understand how do we reach the diagnosis to differentiate between the GI causes and renal causes of metabolic alkalosis. The GI causes and renal causes of metabolic alkalosis, we want to differentiate between the two. The GI causes, in the GI causes, the mechanism is loss of HCl from the stomach. There is the loss of HCl from the stomach, leading to the metabolic alkalosis. So when there is loss of HCl from the stomach, along with the H+ acid, the chloride is also lost. That leads to the development of hypochloremic alkalosis. So the GI causes are also known as the causes of hypochloremic alkalosis, we can say hypochloremic alkalosis. But in these patients, since the kidneys are normal, what is going to happen? The kidneys will try to increase the H plus secretion into the urine. Because the kidneys are normal, they will try to counter-regulate and they will increase the H plus secretion into the urine. But whenever there is going to be increase in the H plus secretion, there is also going to be the increase in the, so there is reduced H plus secretion will be there. Because alkalosis has come, the kidneys will try to retain the H plus. Because there is a state of alkalosis in the blood. So acid needs to be conserved in the body. And that is why when H plus is low, the chloride also in the urine will become low. There will be low urinary chloride proportional to the H plus secretion. But in renal causes, it is mediated by the aldosterone excess state. Mediates the renal causes. These aldosterone excess state causes increased H plus and K plus secretion into the urine. So when the H plus and the K plus secretion is high, along with H plus, there is also high urinary chloride levels. Along with the H plus. And the cases are known as hypokalemic alkalosis. They are known as the hypokalemic alkalosis, we can say. So metabolic alkalosis is the most common defect in the critically ill patient. MCQ again. In this single flowchart, we will find at least 6 MCQs which have come in the past 3 years. Most common defect in the critically ill patient is the metabolic alkalosis. To identify the cause, they are based on urine chloride level divided into 2. The urine chloride is low, GI causes. Urine chloride is high, renal cause. Take this forward. In the GI causes, the most likely cause is the gastric outlet obstruction. Which is going to be there, leading to persistent vomiting. The gastric outlet obstruction leading to persistent vomiting can lead to hypochloremic alkalosis. This gastric outlet obstruction, depending on the age, in children, we will suspect pyloric stenosis. And in elderly, we suspect carcinoma stomach. In children, we are going to suspect pyloric stenosis. In elderly, we want to suspect carcinoma stomach. Number B, when the patient is having the continuous Ryle's tube drainage. Is there. This continuous Ryle's tube drainage is typically done post-operative in a case of GI anastomotic surgery. In a case of GI anastomosis, to prevent leakage along the anastomosis line, there is going to be post-operative. Ryle's tube drainage is going to be continuous in this patient to prevent the peristalsis, prevent leakage along the suture line. And number C, what happens to most medical students when they are waiting for the exam, and worse when they are waiting for the result, is the milk alkali syndrome, that is antacid abuse. So while waiting for the result, waiting for exam dates, our hyperacidity is through the roof. So poor medical student consumes high quantity of Gelusil, leading to the problem antacid abuse we are having. So if we look at alkalosis as the big picture, they can be classified based on urine chloride into 2. Urine chloride is low, GI causes. Urine chloride is high, we come to the other side. Urine chloride is high, it means renal cause. But the most common renal cause are the primary adrenal disorders. The most common cause are the primary adrenal diseases, are the most likely cause of aldosterone excess. Which are the diseases? It includes primary hyperaldosteronism, that is Conn's syndrome, and the Cushing's syndrome. Conn's syndrome and Cushing's syndrome. And all of us know one of the cause of Cushing's syndrome is exogenous steroid. One of the cause of Cushing's syndrome is the exogenous steroid. We are familiar with that. Number B, if there is not an adrenal disease, then we look for chronic drug use. Then you look for chronic drug use. Which are the drugs that cause alkalosis? The loop diuretics and the thiazides. The loop diuretics and the thiazides are going to cause metabolic alkalosis. And number C is the topic of inherited channelopathies, which today's sure shot MCQ is connected to. The inherited channelopathies. These inherited channelopathies are rare in practice, and hence they are a diagnosis of exclusion. They are a diagnosis of exclusion, we can say. Diagnosis of exclusion. If no other cause is there, then we say patient is having a case of channelopathy. So let us take it to the next chart that follows this point. If we consider the channelopathies as the diagnosis, in the inherited channelopathies as the diagnosis, these are channelopathies of the renal tubules. These are channelopathies of the renal tubules that are there. Among the channelopathies, the exception to the rule is Jordan's syndrome. The Jordan's syndrome is the only channelopathy which presents with hyperkalemic metabolic acidosis rather than alkalosis. Exception is the Jordan syndrome, which comes with hyperkalemic acidosis, which rather than telling me aldosterone excess mimics aldosterone hypostate. That is why it is known as the pseudo hypoaldosteronism. They are known as the pseudo hypoaldosteronism is our Jordan's syndrome. Again MCQ. So Jordan's syndrome, pseudo hypoaldosteronism, is exception to the rule, because all other channelopathies present with metabolic alkalosis except for Jordan's. So after excluding Jordan's, what test do we do? In the inherited channelopathies of the renal tubule, what is the test that we do to diagnose the cause? Come on, what will be the best test to identify the cause of the channelopathy? Over to you. So yes, I'm hearing all of you have typed answers that what are the channelopathies, but tell me which is the single best test to differentiate between the three. Which is single best test to differentiate between the three? Are the serum renin levels. Are the serum renin levels are the single best test to differentiate between the type of channelopathy after excluding the Jordan's syndrome. Anyway, that is rare. So based on the serum renin level, we can give three differential diagnoses. Based on the serum renin level, we can reach three diagnoses. When the renin level RAS are grossly elevated, renin levels are grossly elevated, when they are mildly elevated, and when they are unmeasurable. They are not elevated, they are absent. So we are going to divide them into the three. So based on the serum renin level, we are able to differentiate the channelopathy into the three groups. Divide the cases of channelopathy into the three groups. So what is the problem here? The renin level is grossly elevated, means diagnosis is Barter's syndrome. Diagnosis is Barter's syndrome. If it is mild elevated, it is Gitelman's syndrome. And unmeasurable is the Liddle's syndrome. And that is why it is also known as the pseudo hyperaldosteronism. It looks as if aldosterone is more, but actually the aldosterone level, renin levels are unmeasurable in this patient. Again MCQ, Liddle's syndrome, pseudo hyperaldosteronism. So on first column, Barter's syndrome is there, which is relatively the most severe. It is the most severe among the three, followed by the Gitelman's syndrome, which is relatively milder defect. Which is relatively milder defect. We have got it here. So Barter's, Gitelman's and Liddle's we are going to have. So our question of the day is Barter versus Gitelman. So let me take away Liddle's from you. Again, recent MCQ of the last year is the Liddle syndrome. Liddle's syndrome is the autosomal dominant stimulatory ENaC defect. Autosomal dominant stimulatory ENaC defect is the Liddle's syndrome. Because of this ENaC defect, the patient is going to have increased sodium and water reabsorption from the tubule. This increased sodium and water reabsorption from the tubule is going to cause elevated blood pressure. Elevated blood pressure presenting as a young hypertension. One of the differential of young hypertension is Liddle's syndrome. But because of that, counter-regulatory, there is going to be counter-regulatory suppression of the renin and the aldosterone. Counter-regulatory suppression of the renin and the aldosterone. Hence, they are actually suppressed because the fault lies in the receptor itself. Fault lies in the receptor itself. It is mimicked by the exogenous steroid use. Exogenous steroids can mimic the channelopathy Liddle's syndrome. The inherited channelopathy mimics, we are going to write, are the exogenous steroids are mimicking the syndrome. But what we want finally is the treatment. The treatment here is the amiloride. Amiloride is the drug of choice in patient with the Liddle's syndrome. Because what are the points about amiloride? It is a ENaC antagonist. By blocking the abnormal channel, relieves symptom. Also, it is safe in pregnancy. So patient is relatively young, but long-term use of the drug, long-term use offers potential cure. We have to continue it long-term, offers potential cure. Hence, it is associated with the best prognosis. Hence, associated with the best prognosis, we can say. So, when you think of the Liddle's syndrome, it is the best prognosis suspected in a patient who has presented with the young hypertensive. You will consider differential of Liddle's syndrome, and they come with hypokalemic alkalosis, but not because aldosterone is really high, because receptor is active. That is why it is called as pseudo hyperaldosteronism state with cured with the use of amiloride. But in the other two columns, what are we highlighting comparison? Barter's versus Gitelman. In Barter's, there is again both are autosomal recessive inhibitory defect. Both are autosomal recessive inhibitory defect of the sodium potassium 2-chloride ATPase pump. While Gitelman is a autosomal recessive inhibitory defect of sodium chloride co-transporter. Is a defect of sodium chloride co-transporter. The defect in the channel is different. The channel is different in both of them. Channel is different in both of them. ATPase pump being most severe causes most severe defect of water absorption. Causes the defect of water absorption leading to severe hypovolemia. Sodium absorption is not there, leading to severe hypovolemia and hypotension in the majority. Hypotension in the majority. That will cause counter-regulatory rise in renin-angiotensin level. The significant rise is associated with elevated prostaglandin activity. There is also elevated prostaglandin activity in patient with Barter's syndrome. Which drug mimics Barter's syndrome? Barter's syndrome mimic is the loop diuretic. Mimic is the loop diuretic. Mimics Barter's syndrome. But in the treatment, along with hydration, what is important to do? To negate the elevated prostaglandin. They are responsive to NSAIDs. They show responsive to NSAIDs is a characteristic of the disease. Responsive to NSAIDs, it slows the progression of the disease. And this slows to progression is characteristic of Barter's syndrome. Is characteristic of Barter's syndrome. So response to NSAID is a feature of Barter's syndrome. While at the same time, when you look at the Gitelman syndrome is relatively milder. The plasma volume becomes low. There is only mild hypovolemia. Hence, the blood pressure is normal in majority. Since it is normal in majority, the renin-angio level is just mild elevation of RAS. Mild elevation of RAS. Not enough to cause prostaglandin excess. Not enough to cause prostaglandin excess. The mimic is the thiazides. But here, the only treatment is to continue hydration along with magnesium supplementation. Here the treatment is to give magnesium supplementation for relief of the symptom. Can lead to relief of the symptom and prevents the complication. But in Gentleman syndrome, there is no response to NSAIDs. There is no response to NSAIDs. And that is why if you compare between the two questions, when you compare between the two questions, Barter's versus Gentleman syndrome, what are they both? Both are having the hypovolemia. Both can have hypotension. Both can have metabolic alkalosis. Both can have metabolic alkalosis also can be present in both. But our question is asking that which feature differentiates. So hypokalemia occurs in both because of due to high aldosterone state, due to RAS activation. But hypovolemia also occurs in both due to defect of secondary to sodium reabsorption defect. Sodium reabsorption defect. Metabolic alkalosis occurs secondary to H plus secretion in the urine. H plus secretion in the urine because of elevated RAS. This is the problem we are facing. Aldosterone is high in both of them. But response to indomethacin is characteristic of the Bartter syndrome. Is characteristic of Barter's syndrome, because in Barter's, what we will explain, there is gross elevation of the RAS leading to increased prostaglandin levels, increased prostaglandin activity, which is inhibited by the NSAIDs. Inhibited by the NSAIDs. That is why the feature which differentiates between the two. What is our question of the day? Identify the feature, that is response to indomethacin. So I chose the question because we may feel that is it common? This is the question from INI-CET, and we know that these topics are repeatedly asked in different formats. Still we are asked causes of metabolic alkalosis. So I have given you approach table here. So one table we have made today is metabolic alkalosis, again silent killer in the ICU. We divided based on urine chloride into two, GI causes versus renal causes. And we also discussed the table for inherited channelopathies. Inherited channelopathies after excluding Jordan's syndrome based on the serum renin level, we have identified the three disorders. Based on the serum renin level, we have identified the three inherited channelopathy. Again, Barter's and Gentleman remain the commonly asked question. So once you do this topic, I'm sure that we are going to get one question this year. All the very best to all of you. See you on the other side, all of you as a postgraduate doctor, and happy in what you want to do, right? All the very best. Great day.